If you had breast cancer and had an option for a smaller scar versus a long one for your surgical treatment, which would you choose? Or would you select something in between? But if there were other implications of your choice, apart from just the length of the scars, which would be more important? Better survival, quicker recovery, or more satisfactory appearance? Here is where doctors differ, even at the highest level of research. In this video, I will be exploring the diametrically different approaches experts are taking in current research for the surgical treatment of breast cancer. Stay tuned for this intrigue. I shall present what I think, in some way, is contradictory research in this video. Circumstances may be different for each patient, and I encourage you to see your doctor to clarify which approach is best for you. After reviewing the factors that I consider as important for my patient's well-being in survivorship, I will share my preferred surgical strategy at the end. In this video, we'll discuss guidelines and research data pertaining mainly to early-stage breast cancer, which comprises stage 1 and stage 2 disease. There may be some reference to stage 3 breast cancer where appropriate. As mentioned in my other videos, the options for the surgical treatment of breast cancer can be broadly classified into two groups. The first approach is breast conservation treatment, where the cancer is surgically removed with a rim of uninvolved tissue all around, preserving healthy breast tissue. This operation may also be referred to as lumpectomy, partial mastectomy, or wide excision. Radiotherapy is usually administered after surgery. The other surgical approach involves mastectomy, where the whole breast is removed. Women may choose to undergo reconstruction after. Many women who underwent mastectomy experienced body image issues. Hence, reconstruction was developed to alleviate problems with body image issues during survivorship. I will discuss recently published data on mastectomy with reconstruction first and move on to breast conservation later. This is an article published in 2024 about implant-based breast reconstruction after mastectomy, with pictures illustrating the post-operative outcomes. We can see that the length of the scar extends across nearly half the patient's chest. Here is another article, this time about autologous breast reconstruction published in 2026. From the pictures, we can see that this technique leaves scars across the lower abdomen, as well as along half the breast. Some may consider these scars unsightly. To minimize the scars, there are surgeons who advocate the use of endoscopic mastectomy. This is also known as keyhole mastectomy, where the breast is removed through a small incision. In this case, the scars are positioned under the armpit, indicated by the red arrows. You will notice that this procedure was performed for a T1 cancer, which is a tumor size not greater than 2 centimeters. Total time taken for endoscopic mastectomy, including anesthesia time on average, has been reported to be 4 hours. The 3 articles I just presented were published between 2024 and 2026. More than 3 decades before, in 1991, there was a consensus statement establishing breast conservation treatment as preferable because it provides survival rates equivalent to those of mastectomy while preserving the breast. This continues to be true in 2025. Where the expert panelists who convened at the St. Gallen International Breast Cancer Conference believe that patients should be advised that breast-conserving surgery and radiation therapy is usually the best treatment option with comparable or superior cancer control results and other positive attributes. However, it has been known for some time that with breast-conserving cancer surgery, if care is not taken to correct the void created by tumor removal at the primary operation, up to 30% of women have a residual deformity, which may appear similar to some of these illustrations. To avoid this, many experts in the surgery field have described numerous techniques to prevent breast distortion. These are discussed in more detail in other videos. For purposes here, I will share 2 examples. Here is a technique classified as a volume replacement procedure proposed and performed by surgeons in Nottingham, in the United Kingdom, where a lateral thoracic artery perforator flap is used to fill the space created by removal of the tumor. This is the scar that results from this procedure. And in a more recent publication, surgeons described extreme oncoplasty, which is also referred to as reduction therapeutic mammoplasty, because a significant volume of breast tissue was removed from the patient's cancerous right breast. Leaving her left breast untouched at its original size would lead to a significant difference in breast sizes. Therefore, in this case, operations were performed on both breasts to equalize them. Here, the postoperative pictures are enlarged to give an idea of the length of the scars. On the right breast, the scar extends from under the armpit, along the side of the breast, under the breast in an area we refer to as the inframammary fold, then up vertically along the center of the lower hemisphere of the breast and around the nipple. A similar scar is seen on the non-involved breast as well. The operation on the other breast to equalize breast size is medically termed contralateral symmetrization. In regard to therapeutic mammoplasty, there is a reported complication rate of 23.6% by this team of doctors from the United Kingdom. In my opinion, this is where I feel there is some contradiction in current research, where breast cancer surgery progresses in almost diametrically different directions. On one hand, there are surgeons who describe mastectomy and reconstructive techniques through a small incision for the sake of cosmesis. In some reports, these procedures are performed for cancers which appear to be suitable for breast conservation. On the other hand, in the same modern era, there are other surgeons that advocate extreme oncoplasty, where breast conservation is achieved for large cancers through extra-long incisions and additional procedures to ensure good cosmetic outcomes and breast symmetry. So, which procedure is better? May I suggest a middle road? As a surgeon acting in my patient's best interest, these are the factors or criteria I would be reviewing when advising my patient. First, I would assess suitability for the type of operation. If patient and tumor factors allow a choice, then better survival outcomes, shorter operative times, fewer post-operative complications, quicker recovery, and better quality of life in survivorship would be important considerations when recommending what I believe to be the best surgical operation. More information is available in these other videos. But in this video, I will be presenting data to briefly cover only a few of these criteria. In this 2025 report, breast-conserving surgery can be completed in under 75 minutes for the majority of patients. This is significantly shorter than the time taken for endoscopic mastectomy, which, as we recall, takes an average of 238 minutes to complete. In addition, this team of doctors reported that hospital stay for breast conservation treatment was about 1 day. While therapeutic mammoplasty is associated with surgical complication rates of 23.6%, that for breast-conserving surgery is reported to be 1.74%. It has also been shown that breast conservation treatment results in better quality of life outcomes compared to mastectomy with implant reconstruction. It is easy to see from the data I just presented that wherever possible, I aim to do breast-conserving surgery as it is associated with more positive outcome metrics than mastectomy. However, the technique of breast-conserving surgery I apply is not an oncoplastic operation which includes flaps and mammoplasty procedures. It is similar to lumpectomy without reconstruction, abbreviated as LNR in this article. In this study, it was found that oncoplastic breast-conserving surgery is associated with higher risk of complications. With these considerations in mind, I most commonly perform what I term as restorative breast surgery. The final cosmetic results are as illustrated in these pictures for patients who are diagnosed with stage 0 to stage 3 cancers. One of these patients had multiple cancers in one breast, with the largest being 7 centimeters in size at diagnosis. In case they are not obvious, the scars are indicated by the arrows. Restorative breast cancer surgery strikes a balance between the two extremes of keyhole mastectomy and therapeutic mammoplasty. If it is still unclear as to which operation I most commonly recommend, I shall now share as my final data point what I consider to be the most important outcome. In this meta-analysis of more than 1,800,000 patients, this team of doctors found that overall survival is better in patients who undergo breast conservation therapy compared with mastectomy. You now have enough information to be the judge as to which surgical approach I feel is better for women with early breast cancer who are eligible for breast conservation treatment. Ultimately, if given a choice, each patient will have to decide what she feels is best in her circumstances. If you have early-stage breast cancer, I trust you will make a wise choice. Thank you for staying until the end of the video. For your assurance that the information is authentic, the references to the articles cited are made available to allow you to check and verify the data and publications for yourself. If you have found the information useful, please click the like button, share, comment, and subscribe as a signal for more such content. There is more on breast cancer surgery in the other videos from this channel. I hope you will join me there too. Until we come together again, take care.